Thank you very much, Dr. Srinivas, for the invitation. It's a pleasure to uh, see you and to be in your meeting, which I enjoy a lot. Two different settings of percutaneous pulmonary valve implantation will be in the conduits or in the native RVOT. Conduits have a combined stenosis and regurgitation. They account for about 1/4 of the patients, and native RVOT is predominantly regurgitant, and they account for almost 3/4 of the situations. The various valves that are available include Melody valve, which has been the oldest valve, oldest transcatheter valve, which now has around 21 years of age. And then came the Sapien valve, our own Indian valve, my valve, and the venous valves and various other valves. Melody has got the maximum experience in the world, made of bovine jugular vein conduit on a CP stent. It needs a 22 French access. This was the first case in India, a patient who had a Ross procedure. Then there was a Ross autograft failure. He had an aortic valve replacement. And during the second surgery, the surgeon identified tremendous sternal adhesions that he felt subsequent surgeries are going to be difficult. This is a calcified conduit. We balloon test it. And here we are using a coronary to interrogate so that the coronary is not compressed. Then pre-stent it with a CP stent. And this is followed by Melody valve implantation. The valve is mounted on a bib balloon and it is inflated through expansion of the outer balloon. And this is the final result showing a competent valve, no significant PR, and no significant residual gradients. What are the lessons learned from the large use of Melody in a large number of patients? Stent fractures occur, and hence pre-stenting is important. Coronary compression may occur in about 1 to 2%, and so coronary interrogation is mandatory. Conduit rupture may occur in 2 to 3% of the patients, and so use of covered stent is safe to avoid higher pressure in the pulmonary artery, which will facilitate early discharge millimeters of mercury to protect its longevity. So pre-stenting becomes a second step. Unlike other designs like Sapien 3, pre-stenting is important in Melody to avoid stent fractures. Now, can we do it without pre-stenting? This is an example of a conduit which is stenosed, as well regurgitant, and now the balloon sizing is being done and coronary occlusion is checked. Then subsequently we move on to direct implantation of the Melody, but cover the Melody with an Andra stent. You can see that there is an Andra stent covering the Melody and it is deployed in one step. So this is a one-step deployment of Melody and a pre-stent together, and hence this can simplify the procedure. Sometimes RVOTs are reconstructed with bioprosthetic valves, wherein we can use a valve-in-valve implantation. And this is an exception. There is no need to pre-stent. We need to remember that certain valves like Hancock and Mosaic valves are not suitable for post-dilatation. All the other valves can be dilated 1 or 2 millimeters by a high-pressure balloon. So this is a 21 millimeter balloon being dilated by a 22 millimeter Atlas Gold. Coronaries are being checked, and then the valve-in-valve implantation of a Melody, and subsequently you are able to see a competent Melody valve within the bioprosthetic tissue valve showing a good result. Increasing complexity will be whenever there is a distal branch pulmonary artery narrowing, and if we don't address the distal branch pulmonary artery narrowing, the longevity will be affected. This is an example of a tight LPA origin stenosis. I have frozen the still frame. You will appreciate it when the stent is going on. You can appreciate the severity of the LPA origin stenosis, which is being stented initially using a large stent. And subsequently, after the large stent is inflated, then you balloon occlude the RVOT and check for the coronaries. And once the coronaries are not occluded, the next step will be to pre-stent the conduit. So this is the pre-stent, and that is followed by Melody valve implantation. You again check the coronary to confirm that the coronaries are not affected. So this is LPA stenting followed by pre-stenting of the conduit followed by Melody valve implantation. The Melody valve is functioning very well. The last problem will be dense amount of calcification. So here there is a circumferential calcification almost to the tune of 330 degrees, and the calcium is pretty close to the LCA origin as well as RCA origin. And suppose if you are putting in a stent here, it may compress the LCA or RCA. So the mandatory step will be to assess the coronary. So we have 2 coronaries simultaneously wired and we are checking. And here we are identifying that at 20 millimeter, there is no compression. However, on a 22 millimeter, there is a tight compression because of movement of the calcium. This was anticipated, and hence we changed our strategy to deploy a 20 millimeter valve. So this is a 20 millimeter valve. Again, as I told, it's a one-step procedure. We have mounted an andra stent around the Melody valve, and this is being deployed. And here you can appreciate that the coronaries are being monitored, and the coronary flow is completely normal. And here again, the coronary flow is completely normal. So Indian experience of Melody valve has been with about 20 patients, which has been published. Sapien valve is another valve that can be used. The advantage is that it can be used in native valve as well. This is a native valve, pre-stented. And then we are having a Sapien valve in position, which is a balloon expandable valve. The next valve that is available similar to Sapien valve is the My valve. Again, we have about an experience of 10 patients so far. This is a tight conduit stenosis, which is pre-stented. And this is the My valve in position. So the My valve is producing good competence. The next valve that is available is the straight venous valve. Straight venous valve has been used in about 7 patients so far. This is a tight conduit stenosis, and this is pre-stented, and this is the post-venous valve implantation. The last valve that has been used in India in large numbers is the venous flared design valve. And this is the example of a venous flared design valve with the competent pulmonary valve shown on a transesophageal echocardiography. This is the Indian experience of around 29 patients. The last valve that has not come into India is a self-expanding Medtronic Harmony valve, which is FDA approved now. To summarize, pulmonary valve implantation is an emerging intervention, as most of the patients who have been operated in the 90s and 2000s are now having a dysfunctional RVOT. They are coming up for a redo procedure. Melody is the most time-tested valve. The other new entrants are Sapien, My valve, and venous valve. It has helped around 70 Indian patients so far. To tell the difference between the systems, Melody is the simplest valve to implant. You don't need a technician at all. You can crimp on you with your own hands. It's handled completely by the clinician. It's a very flexible delivery system and the most user-friendly among all the other valves that are available. Thank you very much.
And Bharat and others, any questions for the speakers? Dr. Kavita, anything that you want to ask?
One question for you, KK. What's your experience in recanalization of these AV fistula occlusion? And have you ever had to go to the LA, not the LA to PA that you've shown, but the regular fistulas? Have you ever had to coil the distal part of the vessel?
Recanalizations, we've seen a couple of them in the coil era. They haven't happened in the device era because I think mostly it's devices allow for complete occlusion. So we don't have recanalization. You may miss a small fistula that may grow subsequently. And your second question is getting into the LA. I couldn't understand that.
I mean, do you ever have to occlude the draining vessels?
No. We don't. For PALA, yes, but not for fistula. For fistula, we always go prograde into the site, identify the feeder vessel and occlude it. It's very hard to get to that fistula from the pulmonary venous end. I haven't tried that, and I don't think that's been described.